cocaine, let's talk about cocaine use disorder and withdrawal as well. So cocaine use would, I like to think about it, the symptoms would be two things or two categories. Increased SNS, sympathetic nervous system, and then psychotic symptoms or psychiatric symptoms, right? So some of the hallmarks would be, these guys will have hypertension, they'll be tachycardic, they would be diaphoretic, the pupils will be mydriatic. So it's going to look like someone that is in a very fight or flight state now, right? And then with that, you will still now see psychiatric symptoms like mood disorders. They would be restless, irritable, they can't sit still, they're hypervigilant, they're shifting on their seat. Their mood swings will be from here to here, mood lability up, down. They will not sleep well, so they will have decreased need for sleep, and this would look like mania, because sometimes they might even have hallucinations and delusions, just like manic patients. Energy would be all like way over the roof, right? So whenever I see that kind of thing, I'm seeing things, something that looks like panic attack, something that looks like anxiety, also looks like mood disorder, looks like mania at the same time. But I'm not saying that there's hypertension, there's tachycardia, you know, there is mydriasis, there is sweating, flushing. I know that this is cocaine, okay? Now, if they're not nice, they cannot tell you that there is atrophy of the nasal mucosa, or they can go as far as telling you that there is perforation of the nasal mucosa, and that just sells it to you, because cocaine can be snorted, and cocaine will cause vasoconstriction. Remember we said sympathetic nervous system activity, right? So that's chronic vasoconstriction of the nasal mucosa would lead to atrophy, death, and then perforation. So it's like a hallmark sign, and once you see that, just makes it easy for you to pick it. Now for the symptoms, or what you would see when we talk about cocaine withdrawal, maybe you should just review it now and not just wait for withdrawals in general. When they're withdrawing, it's going to be like the opposite of everything that they had. So now remember again, just to recap, when they're using, their SNS is high, your tachy, your seizures, your mydriasis, your sweating, irritability, high energy, decreased need for sleep, decreased appetite, so weight loss, you know, all of those things high. But now when they withdraw, it's like a crash. They get intensely depressed. It's like you throw them below their baseline. They begin to crave more food, so hyperphagia. They begin to need more sleep, so hypersomnia, so they sleep hours and hours. They can even have suicidal ideation in that period. They'll have psychomotor, like slowing down, everything's going to slow down, and then an intense craving for the drug as well, obviously, and then with time they will level out. So that's clear. So a typical question would just look like, oh, they went somewhere for a few days, and then for those few days they were partying, there were drugs, there was alcohol, you know. They will not tell you obviously what the person took, and then the person was so energetic, the person was talking and talking, dancing, the person had need for, the person did not sleep, you know, the person was just high. And then a few days later, the friend will be like, oh, she can't even get up to go to work, she's tired, she also wants to get out of bed, she's so depressed, or I feel so depressed. Then you think of cocaine. All right. So when it comes to opioids, remember that opioids can also be prescribed medically for the management of chronic pain, you know, long-term pain. And it's actually important that anytime you're prescribing an opioid for chronic pain, you also want to give them naloxone just in case of opioid intoxication. You also want to inform the family members that this is like a remedy or an antagonist, and you know, show them how to use it, because opioid intoxication can be fatal. So what are the two things that I typically look out for in a question that would tell me that this is more likely to be an opioid intoxication than any other thing? I look for meiosis, you know, pupil size, and respiratory depression. Obviously, we can see respiratory depression in alcohol and in benzo use, but then you will see other things that do not include the pupil size, and they will hint me that, oh, no, this is more of opioids. You know, for benzos, for alcohol, like we talked about, especially when someone even takes benzos and alcohol together, the amount of CNS depression that they would have would be very, very bad. And yes, they might actually also have respiratory depression. Now, for opioid use, if the respiratory rate becomes less than 8, you want to go ahead and intubate these patients, okay? So that's something that you should have in mind. Now, for the withdrawal from opioids, the symptoms are very specific, so it's hard to miss it. Once you see nausea, vomiting, or GI symptoms, you see yawning, excessive yawning, you see piloerection. See, I've never really seen this combination of symptoms in other types of withdrawal. I just already know that. Muscle aches as well. I just know that this is opioid withdrawal, right? Because in intoxication, the pupils are miotic, tiny. So in withdrawal, what do you think? The pupils will be enlarged, just like as if someone took cocaine, right? So those are some of the things that help me to, nail opioid withdrawal, right? And then how do you look at what are the risk factors for opioid intoxication? So this is somebody who has a history of prior substance use disorder, someone who is taking another drug that together, maybe with alcohol or benzo, that together can, potentiate the CNS depression. Then also people who have children around them, where children can accidentally ingest these drugs, right? So then how do we monitor when we are prescribing opioids? How do we monitor? So there's something that this is something that they like to ask. First, obviously, before initiating, it has to be a conversation between the doctor and the patient. You have to tell them the risk, but you're not also going to let someone suffer in pain because of risk of addiction, right? So this is like a conversation that you have to have with the person who is going to start the opioid, even if they've had opioid use disorder in the past, right? And then something that they love to ask, you don't, screen them during their visits, because they would know. If they were abusing, they would know, and they would, maybe the nights before, they won't take, all right? So yes, before initiating, you do urine drug screening, and at random times when they wouldn't know, or they can't pre-plan, and then they have to sign an agreement that it has to be one prescriber, one prescriber only, or maybe one pharmacy only. And then when they come, there's like a database of prescription drugs. You also want to correlate or check with that database during their follow-up every 1 to 3 months, right? And check, are they getting multiple refills from different places? That's like one warning sign of an opioid use disorder. So the other substances that can show up in your exam, the one I really like, because it's very hard to miss, would be PCP. PCP is phencyclidine. PCP is very easy to nail, because PCP will cause violence and nystagmus. See, the violence is going to be really violent. They're going to pick fights. So it's always going to give you like someone that went to a bar, someone that went to a club, and then because their pain threshold will be like abnormal, so they won't feel pain, because it causes this kind of dissociative amnesia, so they won't feel pain, right? And so they are going to be very violent, and they are going to see nystagmus. You're going to always see nystagmus in questions, and it's easy to pick that. Other things that you can see are hallucinations, amnesia. They won't, like when they get better, they don't remember anything that happened. And then ataxia, right? So that was like pretty easy to nail. Another way to remember it would be the mechanism of action. It actually is an NMDA receptor antagonist, and it inhibits dopamine, serotonin, and norepinephrine reuptake. And there is something that Divine had said once that he likes to use to remember, that SNRIs are used to treat pain, like fibromyalgias, chronic pain, diabetic neuropathy. He just said something that whenever you have your sympathetic nervous system, even if you're in pain, you forget your pain and you run, right? So I think this also helps me to remember that these people have like an increased pain tolerance, so they're always going to get into fights and violence when they're intoxicated, right? And then I think it also binds to sigma receptors. Just in case you see that as a buzzword, it will be like easy for you to remember, right? So other things that can be abused, other substances that can be abused. The next one would be LSD. So LSD is a hallucinogen, okay? LSD is a hallucinogen, and it binds to serotonin receptors. So I like to just remember that it's a hallucinogen. And so if I see that the primary thing that are showing me would be some form of psychosis or hallucinations, or them feeling like they're not in their body, or they're acting somebody else, like depersonalization and things like that. So when I see that that is like the main thing they're bringing up, I'm more inclined to go with LSD. Obviously, there are other things like panic, dysphoria, tachycardia, but these are like very non-specific. You can also see this in cocaine use, right? So I would tilt more towards those visual hallucinations, and euphoria as well, because euphoria is like a mostly general thing for drugs. That's why people get IRB. Another thing will be euphoria, but euphoria is pretty non-specific because you can get them with a lot of drugs of abuse, right? So they might also throw in heroin. Heroin is an opioid, so you remember respiratory depression, constipation, mental status depression, because CNS depression. So in case they bring heroin, you kind of remember that it's also an opioid. I think this is something that used to confuse me when I was taking my exam, right? Next one, let's talk about cannabis or marijuana or THC. So yes, I know that you might see 10 symptoms, but what I specifically look out for me to pick my answer would be conjunctival injection. They would bring that red eye, and the red eye would hint that this is marijuana or cannabis that we are dealing with. Something else that I also remember would be increased appetite. Remember that we talked about cocaine. Cocaine will drop your appetite. It's only when they are withdrawing that they have increased appetite. But in cannabis intoxication, there's increased appetite. There is dry mouth as well. And there is like this thing they call slow reflexes. So they react slowly to things. So you know how like if something is going to come or a car is going to come, the way your reflexes will kick in and you would swerve, they have like slow reaction time. So they might also bring somebody who they saw the car moving, but before they could move, they got into an accident, and then they would bring all these other things, and then they would maybe do a urine drug screen, and they will ask you, you know, what substance you think this is. So the next one is ecstasy. Ecstasy is NMDA, N-methyl D-aspartate, right? But it's commonly, I like to think of it as ecstasy. So when I think of ecstasy, I know that it increases the synaptic levels of serotonin, norepinephrine, and dopamine. So I think of two things: a sympathetic activity and serotonergic activity, because they also like to tie it in with serotonin syndrome, right? Because it can cause serotonin syndrome, especially when you're taking it with maybe another serotonergic agent like an SSRI or something. So when you think of sympathetic effects, I'm thinking hypothermia, temperature even up to 39, 40 degrees. I'm thinking tachycardia, right? I'm thinking of hypertension. I'm thinking of diaphoresis, right? And when it comes to serotonin syndrome, you're thinking hyperreflexia, you're thinking clonus, you're thinking GI symptoms maybe, you're thinking seizures as well. And now one thing that differentiates ecstasy from other ones, when you see hyponatremia, just please go ahead and pick ecstasy, and that hyponatremia can also be the reason for the seizures. So obviously there are going to be other things, but if you categorize the symptoms this way in your head, it will be easy for you to pick ecstasy, right? And then let's talk about methamphetamines. So for methamphetamines, we have symptoms of acute intoxication, and then how do you know that this person has been using it for a long time? How do you know about chronic use? So for methamphetamine, for me, when I see intoxication, I look for violence. I mean, violence is like pretty non-specific at this point, because we've seen it in PCP, but whenever they tell you violent behavior, you don't see it in many other things. So I wouldn't say it's general as well. So I still try to remember violent behavior, okay? I remember movement disorders, like choreiform movement disorders, just like you saying Huntington's. However, there's one thing that I like to remember is tooth decay. These people, in as much as they have violent behavior, they might have psychosis, they might have tachycardia, they might have every other thing. Once I see problems with the tooth, problems with poor dentition, and I see skin sores, I'm already thinking of meth. Right? Why is this? They chew their teeth. So I've just never seen teeth association apart from meth. So they chew their teeth, so that's bruxism, and then they have poor dentition. You're going to say it in the question. And then they have tactile hallucinations, so they feel like bugs are crawling on their skin. So that makes them keep picking at their skin. So they're going to have chronic skin sores. So if I add this to violent behavior, and I'm just like, oh, this is meth use. I think they also have weight loss as well. They also have problems with sleep as well. So that's all for meth. Now let's go to amphetamine use disorder. I'm sure that amphetamine is a very familiar drug because it can be used for ADHD, but it's also has an addictive potential as well. So it can also be a substance that can be abused. So when you see signs of amphetamine intoxication, what are we looking for? First thing is a stimulant. We're going to see sympathetic activity. So if we're talking sympathetic activity, so again, your tachycardia, your hypothermia, your diaphoresis, your hypertension, you're also going to have some psychiatric symptoms like being very irritable, changing their character, stealing, agitation as well, psychosis, thinking, delusions, or somebody is watching me, or they're pacing around. So this can be pretty non-specific as well, right? But obviously when you see that this is like a stimulant effect or a sympathetic effect, their eyes are big, like when I mean eyes are big, pupils are dilated, obviously there are things that you want to cross out, like want to eliminate. So you probably eliminate your opioid intoxication or things that wouldn't necessarily present with hyperactivity, right? And then a caveat that they would always include is that when they watch them in the ED or somewhere, after a few hours, they return to baseline. Okay. Other substance abuse disorders, like maybe cocaine, that can present similarly with hyperactivity, increased paralytic nervous system, amphetamine, they would return to baseline in a few hours. So that's something that you want to keep in mind. And then in the questions, you can also refer to them as bath salts, right? So these are synthetic amphetamines. So you want to keep that in mind. And some serious things that can occur with amphetamine use: arrhythmias can happen, seizures can happen, hypothermia, serious hypothermia can happen, cerebral hemorrhage can happen because increased blood pressure. So yeah, that's all for amphetamine. Now, if someone has ADHD and their parents are worried that, oh, I don't want my child to be started on amphetamine because I have another child who was using and I'm scared that this one might become addicted, what other options do you have to give to them to treat ADHD? So the ones that come to mind that I've seen in questions would be atomoxetine, also your alpha-2 adrenergic agonists like your clonidine, your guanfacine. I think you can also use them for Tourette syndrome, if I'm not mistaken. So these are like non-stimulant drugs that can also be used to treat ADHD. So now there are also drugs that can cause false positives for amphetamines. So the person is not taking amphetamines, but because of some cross reactions, they can also show false positive on your urine drug screening that you want to keep in mind. And these are the congestant that we give for rhinitis, pseudoephedrine, also our antidepressant, selegiline, that's a more inhibitor, and bupropion, dopamine, and norepinephrine reuptake inhibitor can also cause false positives for amphetamine. The other false positive that you want to keep in mind for PCP, a few things that can cause false positive tests for PCP, right, would be ibuprofen. We also have dextromethorphan, that's like it's used for cough suppressant, and diphenhydramine, right? So these three substances, if someone is taking it, it can actually come out that they are using PCP, but they're not, right? Because I know sometimes patients forget to disclose that, oh, they are taking OTC meds for maybe cough or rhinitis or something, right? So you want to just keep that in mind. Also, you want to keep in mind that when somebody comes to the clinic or to the hospital with PCP intoxication, right, all that violence, the aggressiveness, the nystagmus, the ataxia, all of that, you want to give them benzos. Benzos have a way of calming them down. Same thing for cocaine use disorder. You want to give them benzos. So even if they come with that chest pain, and that chest pain looks like it's angina, but then you see other things in the question, you see mydriasis, you see the nasal mucosa atrophy, the perforation, things that would tilt you away from thinking of angina. Maybe the age doesn't fit, there is no history of hyperlipidemia, no generic risk factors for MI, right? You want to like consider all those things in your question. Benzos also will tone down the sympathetic nervous system, right, for cocaine use disorder. So now that we're talking about drugs, what are some medications that can precipitate psychosis? This is also very useful. Like in the question, they will tell you this person has like this comorbidity, maybe asthma, and then they were admitted and then the new drug was added, or somebody who what can you give diphenhydramine for? Maybe someone who is having, let's say, I don't know, maybe urticaria chronic, or someone who has allergic rhinitis, and then they're taking your antihistamine, or they're taking glucocorticoid for maybe asthma exacerbation, and then they present with acute onset, like the onset to be really related to when they started those meds, right? Hallucinations, psychosis. You want to think of drug-induced, medication-induced psychosis. So some things that can cause this are glucocorticoids, like I've said, diphenhydramine, right? Another one is our dextromethorphan that we've mentioned. But that dextromethorphan is an NMDA antagonist, just like PCP. Also, your alpha-adrenergic agonists like pseudoephedrine, your phenylephrine can also cause acute onset medication-induced psychosis. Another stimulant that you might see tested on the boards would be caffeine. Everybody knows that we take caffeine to keep us awake, but how does chronic caffeine use? What does it look like? What does that intoxication look like? Especially like they might give you a patient who has been taking energy drinks, right? So you want to look out for a myriad of symptoms. So jitteriness, anxiety, think of your stimulants. What are you expecting to see in stimulants? So the restlessness, can't sit still, problems with sleep, right? Pressured speech, fatigue. So this might even look like acute mania, right? The pressured speech, the not sleeping enough, but instead of deriving lots of energy from not sleeping enough, they're going to be tired from not sleeping enough, right? Remember that many patients would sleep for only 2 hours and might not even sleep at all, and they are running on 100% energy. So this is different. Because this is like a stimulant effect, you can also see hypertension, you can see tachycardia, you can see palpitation. So you check the history, there will be maybe a new job, new school, exam period, energy, like, something that would hint that this person has increased their caffeine intake. All right. Let's talk about testosterone use. Testosterones are anabolic steroids that can be injected or taken for several reasons. Maybe to build muscle mass. So they might tell you someone who is like a gym rat, someone who is really obsessed with gymming, they love to gym. And then the good thing is that they're going to show you other things that you can see when people are taking lots of testosterone, apart from the aggression or behavioral changes they're going to see. So there are things like increased muscle mass, infertility, right? Because obviously when you're shortening out your HPA axis, so infertility is one. You probably would see erythrocytosis, so hematocrit will be increased. You might see acne, things like that, that hints that somebody is taking testosterone exogenously, right? So these behavioral changes will be related to the period when they started to take testosterone, right? Let's talk about inhalants. Inhalants are one that you would mostly see in young people, teenagers, 14 years to 16 years, so 17, I think. So what you would see is that perioral rash. So because they sniff and then they use the rag, so you're going to see that rash around the mouth. It's very specific for inhalant use disorder. Now, what kind of symptoms are you expecting to see? So before you even get into symptoms, it has a very high, like it's a gas, so very high absorption. And then they're going to get better. Like if 15, 45 minutes, the stuff has worked and they're good. They might even forget that they lost consciousness or forget that, like, they don't know what's happening because it's going to take so much time. So that's also something that you have to keep in mind when you see like a teenager that exhibited some symptoms and then in 45 minutes they're observing, in 1 hour they're good, right? So what kind of symptoms are you expecting? Inhalants cause a level of CNS depression. So it gives me that vibe of alcohol use. Yeah, just stay with me. Actually looks like alcohol, just that the age and then the rash, remember that I think they call it glue sniffers rash. It's very pathognomic for inhalants. So you're going to see euphoria. There might be loss of consciousness, right? So in the acute stage, there will be the tremor, the disorientation, the slurred speech, headaches, hallucinations, just like alcohol. The GI, okay, well, not like about, there is nausea, there is stomach cramping, the cardiovascular system, there can be arrhythmia, respiratory system. So think of something, a gas that goes in through the nose. So you think of wheezing, think of cough, and then obviously irritability, mood swings, aggressiveness. So these ones are like pretty non-specific. Now, when the use is chronic, what are you looking out for in chronic use? So anorexia, problems eating. And this is, like I've noticed, is something that really happens with substance use, chronic substance use. So anorexia, weight loss. Now, I think I got a question wrong, and that was because they brought in abnormal LFTs. They brought in cerebellar dysfunction. They brought in that the person's reflexes were low bilaterally, like in the feet. I'm like, okay, this is neuropathy now. This is alcohol, but no, it wasn't alcohol, right? So inhalants also cause abnormal LFTs. Inhalants cause cerebellar dysfunction when used chronically. Inhalants would cause a B12 deficiency that would lead to peripheral neuropathy, right? So you have to keep that in mind and look for that rash, right? And look for fast recovery, and then age as well is something that will give it away. So next on our list, and we're wrapping up here, would be nicotine. Nicotine we see in smoking, Right. So if somebody comes to you and they tell you that they want to stop smoking, when it comes to smoking cessation, there are really three options that you would see. So one option would be varenicline, and then the other option would be nicotine replacement therapy. So either the long form or the short form. And then the third option that you probably see is bupropion, which we've encountered lots of times when we talked about antidepressants, right? So what's the deal with varenicline? It's a partial agonist at the nicotine receptor, and so far this is like the most effective one, the one that has reduced or increased rates of smoking cessation so far. So what side effect profile are we expecting? Problems with sleep, really problems with sleep, and problems with sleep and dreams. So just think sleep dreams, right? So if you see sleep problems after starting varenicline, you kind of know why. So the other option we have is your nicotine replacement. So this, we have lots of options. So the long-term options, or the ones that have long-acting effect, are your transdermal patches. We can also combine your long-acting with the short-acting, right? So we can introduce the sprays, the ones that look like candy, the ones, you put in the mouth. And it was found out that when you combine this therapy, it's actually more effective than either of them. But this was only second line after varenicline. The patient doesn't tolerate varenicline. And then the last one is bupropion. This would work, let's say, if the person is smoking and also really is depressed, not bipolar depression, but unipolar depression, and you want to treat both. Bupropion would be a good option, but then remember the caveat that you don't give it to people that have seizure disorder or eating disorder, because it reduces seizure threshold, right? So last thing that I probably have mentioned would be opioid use disorder. How do we treat? What medications are available for opioid use disorder? For opioid use disorder, the three drugs you're going to see are methadone and buprenorphine, and then the other one you're going to see is naltrexone. So these other ones are agonists, while naltrexone is an antagonist. These are the three drugs you're going to see come. So let's review for the last time. Alcohol, we have acamprosate, we have naltrexone, we have disulfiram. For smoking cessation, we have varenicline, we have nicotine replacement therapy, and we have bupropion. For opioid use, we have methadone, we have buprenorphine, and we have naltrexone. So buprenorphine and methadone, just like long-acting nicotine replacement, these ones are long-acting. So because they act long, they reduce cravings, right? So obviously, like the lesser cravings, the lesser they're gonna use, if that makes sense. So let's talk about alcohol use disorder. Alcohol use disorder and benzo, I won't say use disorder now, but intoxication are kind of similar. Why? Because alcohol and benzos are actually CNS depressant. So the symptoms of their overuse are kind of the same, while the symptoms of their withdrawal are also the same, right? And then the treatment for acute alcohol intoxication is a benzo, right? Or acute alcohol withdrawal, you have a benzo. Like when they're agitated, you want to give them a benzo to, calm them down. So they're kind of related. But now, what do we see that would make us think that, this person is... I think that everybody has at least encountered an alcohol leak, or somebody who just downed lots of alcohol. So how do they behave? Slurred speech, some measure of nausea, vomiting, some disinhibition. So they're going to act and behave in ways that if they were not drunk at the moment, they won't behave in that kind of way. So that's disinhibition. They want to speak, impaired judgment. They might want to cross road when cars are coming, So all the things that would calm you down normally, they wouldn't have those kind of things. Gait as well. Gait is also one that we always would see. They walk a kind of way. They might want to sing, So when you see that, you would know. And then how do you know that somebody is becoming dependent on alcohol? They would need more and more and more to get to the level that they were getting to. So someone that maybe she was struggling with some sleep disorder, and then she tells you that she's depressed and stuff, and now she takes like two cups or two, I don't know whatever measurement, to sleep. But now after like a few months, she now realizes that she needs more for her to be able to sleep. So that's like some kind of use dependence. Now, talking about this, let's talk about the withdrawal. What are we going to see in withdrawal? So because it's a depressant, when we are withdrawing, we're expecting your neuroscience to go up. So you're going to see things like agitation, you're going to see tremors, you're going to see anxiety, delirium, psychosis, and these are actually some of the things you're going to see in benzos as well. Remember that we already mentioned it. And then when you do objective examinations, obviously you can objectively see seizures. You can not that you can see palpitations, but they can feel palpitations like objectively. And then they will have tachycardia, their heart rate is going to go up, right? Because remember, this is something that chronically depresses the CNS, and now you're withdrawing from it. So it's going to be the opposite. They're going to be hyper. And there's now a particular set of classifications or syndromes now that we would use when we talk about alcohol withdrawal, right? So that's the one we're going to talk about now, like based on time. And then another thing that should give you like a high suspicion for these withdrawal things, they always like to bring it in the cases of somebody who was just hospitalized for a surgery, and then he starts to, I'm going to mention the symptoms now, but he starts to exhibit the symptoms. Or someone who was in a home and now he has been moved to a nursing home. You know, just look at it like somebody who was moved to a place, from a place where they would otherwise have access to alcohol, and then they're in a place where they don't have access to alcohol, right? And then it pushes them into withdrawal. So right, so the first signs of alcohol withdrawal from this like 6 hours to the first day to 24 hours are the things that we've kind of already mentioned. So your tachycardia, your anxiety, not being able to sleep, diaphoresis. These are just going to be hyper, and you're like, what's going on, right? And you look at the question and then you would see these things that we just mentioned. 2 days post-op or 1 day post-op, obviously not be taking alcohol because they're going into surgery, right? And there's also going to be some measure of GI upset, but their orientation will be intact. They know where they are. They know what time is it. They know their names. Okay, so their consciousness, nothing is affected. Please, that's like very important to know. Then, number 2, the second stage will not be the seizure stage. So this happens around the second half, like 12 hours to 2 days. So within that period, they're prone to having seizures. So it might be one seizure, it might be multiple seizures. So they just have like your generalized tonic-clonic seizures. It's like the ones where you move and then you become like really stiff and still, right? So they might have that. And then the next stage is what we call alcoholic hallucinosis. So just like the name, hallucinations are going to be the most important thing we will see in this stage. And this stage happens around the same time as the seizures, right? From 12 hours to 48 hours. So it might be tactile hallucinations. They tell you that they feel bugs crawling on their skin, or it might be visual. They are seeing things that are not there. I'm seeing animals. I'm seeing some bright colors. You know, my pets are here and those kind of things. Or they're hearing things. So auditory hallucinations, okay? But orientation is intact and their vital signs are stable. So when I say that vital signs are stable, not that they might not have tachycardia, they probably will, but tachycardia is still stable, if you get what I mean. It's not jumping up and down. And then the most severe one, which is like the last one to occur, would be what we call delirium tremens. So let's dissect the words. So this one happens last, so after the 2 days, so 48 hours to the 4th day, 96 hours. So it's going to include the agitation, it would include your diaphoresis, it would even include probably seizures, might include your hallucinations that you've had. However, the hallmark of this one is that there's going to be confusion. So at this point, they lose intact orientation. So this is the point we're not going to say there's intact orientation again, and the stable vital signs will become more stable. So in as much as you're going to see tachycardia, you're going to see hypertension, you probably will see fever as well, right? So this one looks bad. So you will see the progression and it looks bad, and then you will see the number of days. So this is like from day 2, day 3, day 4, right? This never happens in the first day, at least as per questioned. So that time frame and the severity of the symptoms. So always check for stable vital signs, check for orientation. Then you'll be able to like eliminate, okay, it can't be this and it can't be that. So I hope that's clear for this 4. So just to dissect again, your mild withdrawal stage, 6 hours to 24 hours. Then your seizure stage, 12 hours to 48 hours, the same as the hallucinosis stage, alcoholic hallucination. So this is purely hallucinations, and that's also the same time, 12 hours, 48 hours. And then from around 48 hours to 96 hours, we are expecting to see delirium tremens. And how do you treat benzos? Benzos are going to, remember that we said that benzos are CNS depressant, so it's going to like try to tone down, because you know your alcohol works in the CNS as well, so it's going to try to tone it down at that point. Some other things that would help you know that this person is having or suffering from alcohol use disorder would be they might give you some physiological things. When I mean physiological, I mean it's not psych. So they might show you a full blood count, and then you see that this person has megaloblastic or macrocytic anemia, right? MCV is going to be greater than 100. That should point you. You might also have thrombocytopenia, low platelets should point you to that. When they give you signs of elevated liver enzymes, and then you see that your AST is higher than your ALT, that should point you to that, because the parenchyma of the liver is damaged in alcoholic hepatitis. Okay. Another liver marker that is elevated also in chronic alcohol use would be your gamma glutamyl transpeptidase is also elevated as well. And then sometimes they might just give you signs of malnutrition. They might give you, you would see like your vitamins, your folic acid, your B1, they are all reduced. They should also like hypoglycemia as well, should also tilt towards chronic alcohol use disorder. Okay, let's say we are treating somebody for alcohol use, right? So this is someone who comes to you and they tell you that, look, I'm really worried. This thing is costing me my job, or my wife is threatening to leave me. I want to be there for my family. My boss has warned me. No, they're just really eager to stop alcohol. And obviously, there is the part of psychotherapy. There is motivational interviewing where you want to know how ready are they, and then obviously using their own internal motivation to encourage them and help them overcome that. But when they tell you that they want drugs or they want help with pharmacotherapy, what do you prescribe? So what are the first lines? When it comes to first line, 2 drugs. Remember your natroxone and then acamprosate. You must have seen natroxone come up in opioid use because it's an opioid antagonist as well. However, it's a first line drug for alcohol use disorder. If somebody has liver disease, you might want to be careful. You wouldn't pick a natroxone in your exam because it's hepatotoxic, right? And then if somebody is already taking opioids for maybe prostate cancer pain, something, but they have a legitimate use of opioids and they are prescribed opioids, you don't want to also give them natroxone because natroxone is an antagonist, so it might precipitate or push them into opioid withdrawal, right? So you don't want to do that. Then you probably tilt towards acamprosate. However, in renal patients as well, you don't want to also give them acamprosate, okay? So you titrate it in renal and failure patients, or you just give them something else. In the event that this person is not eligible for acamprosate and they are not also eligible for natroxone, then we go to our second line, which is disulfiram. And acamprosate, I didn't say it's a glutamate receptor modulator, right? And then for disulfiram, I know that we must have seen this a lot, especially during step 1 studying, where we are told that it inhibits acetaldehyde dehydrogenase and then just increases and makes like the levels of acetaldehyde just really come up a ton. And because it causes some like unpleasant effects. So whenever they remember the unpleasant effects of acetaldehyde, they might not want to take it again. However, this is like very is useful for people that are highly motivated, because come to think of it, if I know that if I take alcohol and I take disulfiram, I'm gonna feel bad and I really want to take alcohol and I'm not really serious about stopping, what will I do? I'll take my alcohol, but I won't take the drug and everything is okay, right? So you're only going to consider this for people who are highly motivated. So I think that's all for the pharmacotherapy of alcohol. Now, let's talk about the sequelae of alcohol use that is commonly tested. So the first one that everybody is familiar with would be Wernicke's encephalopathy, and we correlate that to B1 deficiency, that comes through because of malnutrition in alcohol use. So what do you see that would tell you that, oh, this is Wernicke's? So you would see confusion, you would see some ocular dysfunction. So it might be diplopia, it might be nystagmus, but there's going to be something going on with the eyes, also something going on with the gait. So when you see these 3, you can pick Wernicke's, obviously, like you would have read through your question. And it's important to know that Wernicke's is reversible. That's why we are going to give them vitamin B1, we're going to give them glucose, right? And then something else they like to test would be the location of the lesion. Sometimes they might even give you an MRI. So the lesion is located in the mammillary body. So the buzzword would be atrophy of the mammillary bodies and the dorsomedial thalamic nuclei. So just in case they bring in the neuroanatomy. right? And then the other one would be Korsakoff psychosis. So this one is irreversible. Once we get to this point, there is no going back. So what do you see in Korsakoff? Lack of insight. They don't even know that something is wrong. They're the one that thinks that they're lying, but they don't know that. So frontal lobe changes. And then if they bring in the neuroanatomy, where are you likely to find the lesion? You're going to be the lesions are going to be found in corpus callosum and the anterior and medial thalami. So let's review. So for Wernicke's, the lesions are in the mammillary body, so atrophy, and then the dorsal medial thalami. For Korsakoff, we're in the anterior and medial thalami and the corpus callosum. So there is this other rare one that I've actually never seen tested. I only saw it in the options when I was doing my UWorld for step 2. And that disease, I hope I'm pronouncing it right, is called Macchiafava-Bignami disease. So in this one, what's going on? We have damage also to the corpus callosum, right? And then this is because of chronic alcohol use and chronic malnutrition. So it's not an acute process like in Wernicke's, right? And what are some of the symptoms that you would see? So you can see cognitive impairment, you can see seizures, you can see dementia, you can see behavioral changes. So for me, I don't really cram all the symptoms, right? So I just think about it. Okay, the alcohol use damages the cerebellum. So okay, dysarthria is possible, and I've learned to associate alcohol with seizures, right? So when I just add like a few symptoms, and then because I would also look into my history and see that there is some heavy drinking here, so they're going to bring like a homeless person, someone that has been hospitalized multiple times for pancreatitis, someone that has been enrolled in Alcohol Anonymous but he was not consistent. They're just going to give you something to tell you that, oh, this thing has been going on for a long time. And then something else I wanted to point out, that I said that alcohol causes cerebellar degeneration, right? The problem here would be in the vermis. So it's going to be truncus or truncal ataxia, right? So the problem is going to be with their gait. Okay, but when it comes to extremities, like your finger nose testing, your heel testing, these are like the ones where in the other cerebellar tracts that are found in the lateral lobes, those ones are not affected. The problem is going to be in gait, in your the part of the cerebellum that controls the trunk and all the extremities. So that's also like really high yield. And then another place I've seen them test Wernicke's when it wasn't alcohol would be in hyperemesis gravidarum. That was like such a very weird, tricky question. But then if you think about it, people or pregnant women who have hyperemesis gravidarum, they vomiting, and they're not able to keep anything down. So what do you have? Malnutrition and also vitamin deficiency. So it was like a very weird association, but I did see it come up a few times. Now that we're talking about alcohol, substance use disorder, I want to talk about something that it's very related, which is homicide and suicide, right? Because substance abuse, ethanol use are risk factors for both, independently, of course, of homicide and suicide. So what are the things that you would see that would make you think that somebody might be at risk for homicide? So the first thing would be the gender, males, age. So a young male who is unemployed, who has access to firearms. So those three, I just want you to keep these three in mind. And the other things are substance abuse, which we've kind of already covered, history of antisocial personality disorder. So these are like the people that just literally think of it as antisocial. These are people that before 18 they had conduct disorder, now they're antisocial. So not just that they don't like to have relationships, not just that, they are also really prone to destroying things. When they are below 18, they assault people. They don't care about how people feel. They're the ones that are likely to start fires, do things like that, kill pets, torture animals and people as well. So that is also like a risk factor for homicide disorder. Another one would be any history of criminality or violence in the past. Also, history of child abuse is also one risk factor for homicide. But top of the list, anytime they ask you that, okay, what is the chance that this person will complete this or do this, and then there is like a male, he's young, he's unemployed, and he has access to firearms, you want to pick that first. I'm talking about suicide. Suicide, we have suicide ideation, suicide attempt, and then obviously completed suicide. So ideation is like mostly like they can tell you an MDD patient or a psychiatric patient or someone who has chronic pain, someone who has just been diagnosed with cancer, and they're telling that they actually desire to kill themselves. They have those thoughts. They think about how they might want to do it, right? They might even have completed it in their head. So that's suicidal ideation. So you always want to query depressive patients for those kind of things, or even just your psych patients. And you know that even in teenagers, adolescents, we have one of the screening things that we have to do for them is to screen them for depression and obviously suicide risk as well. And then when somebody has tried but it wasn't successful, so they tried to commit suicide by any means but it didn't work, that's already an attempt. So that's a suicide attempt. And then obviously like suicide can now be completed. So that's like the end of the spectrum. So they love to bring this up, and then they want to ask you that which of these is the most important risk factor for this person completing suicide. The most important risk factor would be a previous attempt. So someone who has attempted suicide in the past is more likely to complete suicide, right? And in this case as well, age and gender also come into play. So males age more than 45 are also risk factors. Access to firearms as well, because 50% or more of suicides are completed by firearms. So any access to or possession of firearms is also a risk factor. Now we also have our personality. Now we also have our substance use disorder, ethanol use disorder, substance use, cocaine, opioid. This can also increase the risk of suicide. Chronic pain, chronic illnesses like cancer can also increase the risk. History of abuse as well, sexual assaults in the past can increase the risk. Socioeconomic status like unemployment as well, or people who do not have social support, they live alone, they don't have friends, or they just have limited contact with people, or people whose parents have died early and they've kind of grown up alone as well. Then any history of a recent psychiatric hospitalization, because I mean anything that would demand that you be hospitalized as a psychiatric patient kind of sounds serious. So that's like one risk factor as well. And then your common psychiatric disorders like major depressive disorder, psychosis, schizophrenia, bipolar disorder as well. These are also all risk factors, but the most important would be previous attempts. It will be the gender, males, age as well, and access to firearms. But you want to also like keep this at the back of your mind when you see people that have chronic illnesses. You want to ask them all these questions. Do you think about this? Do you and if they mention those kind of things, you want to also like your suspicion should be high. When it comes to adolescents and we are able to establish that they have a suicide risk, you want to hospitalize them. Yes, you will tell their parents, but you don't need their permission to hospitalize these patients. So I hope that's clear.